Okay. Okay. This is the last in our reproductive series. Now we are going to talk about, in chapter 59, male reproductive disorders. Let's talk first about erectile dysfunction, also known as ED. This is really important because it affects so many men. So it's really important for you as a nurse to know, one, what it is, why it occurs, and what we can do about it. So erectile dysfunction is basically the inability of a man to hold and maintain an erection, which is usually very devastating to most men, but there are a million reasons that this can occur, which I'm not going to read all these, but you do need to know that all of these can play a role in male impotence. Impotence meaning inability to get and hold an erection. So a couple things, like, for example, perineal trauma. This you're going to see in, especially in your military patients, like veterans who have come back from the war and have gotten trauma to their perineal area, shrapnel to that area, some hormonal problems. A ton of drugs can cause this, so make sure when you're talking to your patients, you're getting a good health history, you're finding out what medications they're on, because a lot of the antihypertensive medications will lead to this, because the way that a man gets and holds an erection is that because the penis gets filled with blood and holds the blood there. Well, if you've got a person on a medication that dilates the vessels and keeps the vessels open, then they can't keep and hold an erection. So many of the men who are on antihypertensives might have some struggle with erectile dysfunction. Men who have plaque, atherosclerosis, that are on the statin drugs, they may have a lot of problems because it's the arteries that go into the penis that need to keep the penis erect. Well, if all of those arteries are filled with plaque, they can't get the penis in there, can't have an erection. So men that have anxiety or depression, a lot of mental issues can go into this. So there is a plethora of patients who have diabetes, complications of diabetes. So quite a few reasons. So you've got to make sure that when your patient comes in and he is complaining of erectile dysfunction, that you're getting a really good health history, because there could be a million different reasons that are causing it. So what do we do about it? Thankfully, we've got some really good drugs now. The PDE5 inhibitors, namely Viagra and Cialis, they will produce smooth muscle relaxation and vasodilation of the blood vessels, the two things that you need for a man to get and hold an erection. Just relax a smooth muscle, dilate the blood vessels, it fills up that penis, and he can have and sustain an erection. Now, here's the thing about these medications. They're usually, we prescribe our men to take them anywhere between 30 minutes and 4 hours before they are planning on sexual intercourse. However, you can't just take one of these little pills and then the man can expect to walk around, with an erection. There has to be sexual stimulation. So he has to engage in some kind of sexual stimulation for the erection to actually take place. It's not just like a little magic erection pill. He actually has to, participate. It could just be masturbation if that's the thing, but there's got to be some kind of stimulation. The other problem with erectile dysfunction is smoking. I don't know if that was on the other screen, but smoking definitely causes impotence. But here's the really important thing as a nurse. If your patient is taking like Viagra or Cialis, you've got to be really careful. They've got to check with their doctor first, because as I just said, it will relax the smooth muscle and it vasodilates. But if the patient is also using a nitrate for their heart, which also vasodilates, remember the nitroglycerin, how we use the nitroglycerin to dilate those coronary arteries, it can lead to really severe hypotension. So you need to be very careful in your patients who are complaining of erectile dysfunction, and they might be complaining that because they're on a hypertensive medication. They might be because they also have cardiac disease. They're also on nitrates. You got to be really, really careful with that. So just because a person has hypertension or has diabetes does not necessarily mean that it's going to interfere with the inhibitors of this, but it's the nitrates that are a big one with Cialis and Viagra, so be careful with that. You also need to teach your patient what the side effects of going on Viagra and Cialis are, and this is important because this affects millions of men. And they're going to ask you as the nurse about it. So knowing that these medications cause vasodilation, you can tell them to look for things like headache, flushing, dizziness, because those are all classic symptoms of, or side effects of vasodilation. You can take it as many times as you want a day, between 30 and 40 minutes before intercourse. I guess if somebody's going to have intercourse that many times a day. And the other thing is that you need to tell your patients who are on these medications to assess for priapism. Priapism is the word for an erection lasting longer than 4 hours, and that can actually be a medical emergency, because what happens is the penis becomes erect, and then the blood that is causing the erection can't get back out of the penis, and it can actually start necrosing the penis. So it's a medical emergency if that happens, and if the erection doesn't go away after 4 hours, they've got to seek medical attention, because they're going to have to go to the ER and get that blood that's in those arteries, got to get that to drain, or it will necrose the penis. Nobody wants that. The other thing, so sometimes men who are having erectile dysfunctions, they can't take Cialis or Viagra just because their heart disease is so bad, and so they still want to engage in sexual intercourse. They've got partners that this is important to. So we do have some different techniques besides medication that can help men who have erectile dysfunctions. They can actually, we've got some injection things that you can just inject right into the penis. Most men don't love this. There's also some other things that they can implant, like some of these rods that they can put in, I don't even know how to describe it. They're bendable, so you can bend them in the down position, and then when the man is ready to have sexual intercourse, he can actually bend it and it will stay up. And so it's actually inside, and it will do the work of like the muscles and the blood vessels. They have little pellet things they can put in. Some of them, instead of like this one is malleable that moves like this one is inflatable, and it has like a little reservoir, so when the man is ready to have sexual intercourse, he just pumps up this reservoir, which is inside the abdomen, pumps it up. These are inflatable, and so these inflate up, and then when he's done having intercourse, he releases it and they go back down. So there are some other options for men who have erectile dysfunction. So I just wanted to let you know that, because again, it's such a big problem. And here's the other thing, as a nurse, nobody wants to talk about it. It's all embarrassing. Nobody wants to talk about it. Nobody wants to admit that they have erectile dysfunction. But if you go in and just act like it's every other health issue that we deal with, then it will give your patients a safe place to talk about it, and then you can help them deal with this problem and improve their quality of life. So don't ever feel like weird or embarrassed. Just, if they had hypertension, we'd help them with that. If they had diabetes, we'd help them with that. If they've got erectile dysfunction, we're going to help them with that. That's what we do. We're nurses. We help people. So that's that. So let's talk a little bit about testicular cancer. Testicular cancer is not super uncommon. It tends to show up earlier in life, between the ages of 15 and 35. And again, it's usually painless. Similar to breast cancer, testicular cancer is usually painless. Not so with oh, never mind. I'm going to leave that for the next slide. So again, if you're not familiar with this, I forgot to put up my anatomy slide. The testicles are down here, they produce the sperm, and it is held in the epididymis, and then it goes up through the vas deferens, goes through the prostate, which we're going to talk about in a little bit, and out through the penis. The prostate lubricates the sperm, which is part of the ejaculate, and testicular cancer occurs right down here when you've got little tumors down there. Not super common, easy to treat. It does like to metastasize early, which is why we also have our men doing self-testicular exam, but really responsive to chemotherapy. So this is one of the easier kinds of cancers, especially if we can identify it early. Most common person that had this that you would be familiar with is Lance Armstrong. Now, there is a myth that riding bike will cause testicular cancer. That is a myth. However, the most famous bike rider in the United States, Lance Armstrong, ended up with testicular cancer. So I think this is, if you just go out and ride a bike, nope, you're not at any higher risk for developing testicular cancer. If you're on your bike 20 hours a day like Lance Armstrong, maybe. I don't know, but according to the Testicular Cancer Association, there's no link. They do, most people who develop testicular cancer, it's usually only in one testicle. They can remove that one testicle very easily in a surgical procedure, and the man is still able to produce sperm and have children. It's not age related, and the size of the testicle really has no risk factors for the development of testicular cancer. So this is how you teach your male patients to assess for their testicles for lumps, because just like breast cancer, testicular cancer will have a lump in it. So you teach your male patient to like cup the testicle, palpate the testicle, gently rolling it around. It's, you know, about the size of like a plum, or like a plum. It should be nice and smooth in there. And again, no dimpling, no discharge, things like that. So you also want your male patients to be very familiar with what normal testicles look like. The testicles can also develop some other abnormalities in them. Don't spend a ton of time on this. I just want you to be aware that your patients can develop a hydrocele, meaning fluid in the testicular sac. They can develop spermatocele, sperm. They can develop a varicele. The one thing about varicele is the dilated veins down into the testicles. This is not super uncommon. However, in the testicular sac, a varicele is like these tortuous, bigger veins. Not uncommon. A lot of men have that. The problem with this is because the blood in here now is sort of flowing more and the arteries and the veins kind of swish together, it can get hot. And then as the sperm passes up through here, because the heat is more, it can actually destroy sperm, and variceles are one of the leading causes of infertility. So if your male patient says that they have a varicele and they have been unable to conceive, it could be the varicele. One easy way to treat this is to have the man wear boxer shorts where his testicles can be further away from the skin, rather than tight underwear where it keeps this up closer to the skin, which would make the situation worse. So anyways, those are just some different things that can occur. Now, when a man does have testicular cancer, the surgery for it is pretty easy. So an orchectomy is the removal of a testicle. So if one testicle is identified to have a malignancy in it, the procedure is pretty easy. They just open up right next to the penis. They go in, they get the spermatic cord, and they cut it, and then they just remove the testicle, and that's it. And sometimes, depending on if it's metastasized, they might do a little bit of radiation to this area. So again, you're going to watch for excoriation, things like that. But usually it's not. Usually it's not a big deal. Sometimes, if the patient has prostate cancer and the prostate cancer has moved forward into the testicle, then they will move this. They remove the testicle with the prostate too, which is why the slide is talking about both prostatectomies and orchiectomies with the testicular removal. So sometimes both of them are done. Now, when the testicle does get removed, you might have some side effects with your male patients that are similar to menopause, like hot flashes, erectile dysfunction. They may not want to have sex as much. That's loss of libido, irritability, weight gain, osteoporosis, very, very similar things that your menopause patients would have. And we didn't really talk about menopause when we did the female reproductive stuff, but we can go over that more in class. So that is testicular cancer. I want to talk about benign prostatic hypertrophy, BPH. Hugely important. A ton of men have that. However, I'm going to bring in a guest lecture for that, so I'm going to skip through this really fast, and I'm going to have a very good doctor come in and talk about this. But I do want you to go back, make sure that you know everything on this slide. This is the bladder, this is the urethra, this is the prostate. This is the seminal vesicles, the vas deferens that carry the ejaculate down, comes in through here. This is normal. This is an enlarged prostate here. So that's BPH, and we're going to talk a little bit about this. It can cause urinary retention because this is the urethra, it's getting squished. If you have urinary retention, that can lead to UTIs, urinary tract infections, and sepsis. It leads to incomplete bladder emptying, and then you get bacterial growth in the urine. Once again, I'm going to skip this because I'm going to bring in a guest lecture, but this is just the enlarged prostate here. I'll talk about that in a second. And this is the one way to treat BPH is with this procedure called a TURP, a transurethral resection of the prostate, where they just go up through the urethra and they resect this prostate and open it up. I'm going to tell you about that in a little bit. This is a good, if you want to watch it on YouTube, I would Google TURP and watch the procedure. And again, most of that is just done through a scope. We're going to talk about that in a minute. Post-operatively is important for a nurse. When you're taking care of a man who has undergone a transurethral resection of the prostate, they will have a special catheter in place because they are prone to developing blood clots. We want the blood clots to stay flushed out. And bladder spasms is a big problem and a painful problem. So one, we prevent bladder spasms. Two, we make sure that bladder is getting flushed and that we don't have blood clots occluding that catheter. You're going to expect normal to pink urine, not bright red bleeding. And you need to make sure that the irrigant that's coming out is also diffusing back out into the Foley catheter. And you've got to accommodate both the infusing fluid as well as the amount of urine that your patient is making. I'm going to show you a picture of that in a second. I think it's this next. Okay, this is the catheter. So see how in a normal Foley catheter, you usually just have two prongs. You've got the balloon, and then like the catheter, you'd hang this, attach that to the catheter bag. Well, this is a 3-prong one. Then you hook one up to fluid that gets drained in, and then the other one is going to come out through the actual Foley bag. And that's how you irrigate your patient after they've been having a transurethral resection. So they get the bag of fluid up here, it goes down into the bladder, flushes the bladder, makes sure that there's no blood clots, and then drains out into the catheter bag. And it's these two solutions that you need to make sure that the amount that's being infused is also coming out, plus however much urine. So at least, you know, at least 30 cc's an hour should be in this bag. Okay, let's talk a little bit about prostate cancer. I'm going to come back to BPH in a minute when I bring in my guest lecturer. So again, very similar to the other kinds of cancers that we've been talking about in this body system is identification and screening. The incidence of prostate cancer goes up after the age of 50, unlike testicular cancer, which is going to start earlier in life. And the way that we identify prostate cancer is through digital rectal exam. So if you're doing an assessment on your patient, especially if you're working as a nurse practitioner or in a urology clinic, you're going to learn how to do digital rectal exams, and it's just a finger insertion into the rectum, and you can feel the prostate right at the very tip of the finger. It's about this far up into the rectum. It should feel like a round, smooth, almost the size of a walnut. You can feel it here. When that starts getting enlarged, it could mean that your patient has something wrong. So the first thing is the digital rectal exam, and then we can do something called a PSA, is a prostate marker. It's, you can get it in the blood, and the PSA level should be less than 4. When that PSA level starts increasing, it could be a sign that your male patient has prostate cancer. However, this is super, super common. Some studies say if a man lives up into his 80s and 90s, the chance of him developing prostate cancer is like 80%, super high. It's typically very slow growing, especially later on in life, not real aggressive. If a man develops prostate cancer early in life, like 40s and 50s, then it's a little bit more aggressive, but not a ton later in life. However, that being said, if it's identified, they will usually they will remove it. One thing that they can do is a transrectal, and you'll see here they're going into the rectum, a transrectal ultrasound. So this is a little ultrasound machine going in there and looking at the prostate just through the muscle rectally. So you'll get a transrectal ultrasound, and that will identify that there's a mass there. And then the digital rectal exam will feel enlarged and abnormal. You can get ultrasound, CBC, BUN creatinine levels, because if it's starting to push up on the bladder, the BUN creatinine levels might be starting to go up, because this would be one of those reasons to have a post-renal obstruction. Remember, during renal week we said there might be some post-renal problems leading to renal insufficiency. This is one reason. So your BUN and creatinine are going to go up. Remember, your BUN should be between 8 and 20. Creatinine is about 0.4 to 1.4 levels. So these are all indicative that your patient may have a prostate cancer, and then they would go in and get a little needle biopsy, find out what they have going on. May have to do a prostatectomy, meaning a complete removal of the prostate gland. The purpose of the prostate gland is to lubricate the ejaculate, so men who don't have a prostate gland might have a little bit of drier ejaculate. So that's just something to let your patient know if they're going to go for prostatectomy. Another thing that men can get a fair amount is prostatitis. Unlike prostate cancer and testicular cancer, prostatitis is very painful. BPH, enlarged prostate, is also not painful, but when that prostate gets infected, that is extremely painful, and pain control becomes a big problem. Prostatitis is just an inflammation of the prostate gland itself. This can occur for a number of reasons, like farmers who are riding tractors all day long, men that are sitting constantly. They can just get an infection of the prostate, and it's extremely painful. Constipation can cause it. One thing that helps it, all your male patients will be happy to hear this, is relieving that prostate gland, emptying the prostate gland. The way that you empty the prostate gland is through either masturbation or having intercourse, because the ejaculate that comes in here, if you can drain it, you relieve some of the pressure and the man will feel a lot better. So that's actually good news. If your male patient has prostatitis, he will be very happy to hear that. And then we put the patient on antibiotics, and typically it will clear up, and you've got to treat them for pain because it's extremely painful. So that's prostatitis. A vasectomy, many men use this as a form of birth control because it is a lot easier for a man to have a vasectomy than it is for a woman to have her fallopian tubes tied. Many men will come in and request this. It's a very simple outpatient procedure. They just bring up those the vas deferens and cut them off, and that's it. The man will still make sperm, but the sperm won't get out through those the vas deferens, but the man will still have ejaculate because the vas deferens are still intact, will still go through the prostate gland and out through the penis, so he can still have orgasms and ejaculate. It's just there's no sperm in them. But the problem here is that so after the man has a vasectomy, then he typically waits like a week or two, and he can still they typically say that he should wait like a week to 10 days to 2 weeks to have intercourse again. Then he can have intercourse, but he'd better be using something else, because you would never tell him that it's okay to have intercourse again until they take a sample of the ejaculate and look at it in a microscope, make sure that there's no sperm in there. Otherwise, there could still be sperm in there, and then he could still get somebody pregnant, which is probably not what they want if he's gone for the vasectomy in the first place. So, just after a vasectomy, a little bit of ice packs, a little bit of rest in that area for a while. Typically, it's not a big deal. They can have sexual activity again in a week. This is what it looks like. So they just pull these vas deferens up, they snip it off, and there's just a small little incision right there, and it's a really easy peasy way to have birth control. I probably should have put this in the beginning. This is what they say, like if they'll say check your lemons, that means it's not a medical professional way to say it, but to tell a man to make sure that he's doing testicular self-exam. But this is just the anatomy. You should know this. Bladder, urethra comes down this way, testicles here, makes the sperm, carries the sperm up through the vas deferens, down here into the seminal vesicle. The epididymis goes down into here where all of the ejaculate is added and comes out through the end of the penis for the ejaculate, and that's how he gets somebody pregnant. So that's end of this part. Now I'm going to bring in my special guest for our BPH lecture. Stay tuned. I'm going to start another thing.